attending this, those who are attending this webinar. So today we are again back to school Wednesdays. We are discussing infant with dystonia. So the presenter will be Dr. Dhruv Sandeep, who is pediatric neurology fellow with Dr. Harsh at Narendra Modi Medical College and LG Hospital, Ahmedabad. And Dr. Harsh is a dear friend of mine and who has done his DM from AIMS, New Delhi, and presently is consultant pediatric neurologist at Zydus Hospital, Ahmedabad, and also is an honorary consultant in LG Hospital and Medical College. He's got many publications and chapters, and he's got an original award for original research on epilepsy tool, and his mainly interests are epilepsy, neurogenetic disorders, autoimmune disorders. So today we are lucky to have amongst us Dr. Atin, who is professor of radiology at All India Institute of Medical Sciences at AIM, New Delhi, and he's our teacher and is taking pediatric neuroradiology classes since so many years, and we have been lucky to have him today. So over to Harsh. You can start the session, Harsh.
Yes, sir. So exactly, we are lucky to have Dr. Atin sir with us, and I also invite Dr. Dhruv Sandeep to start to share his case and the further proceedings. He is currently already introduced. He is a fellow at LG Medical College, LG Hospital, and Narendra Medical College, Narendra Modi Medical College. Dr. Dhruv Sandeep, you can start now, please.
Yes, thank you. Good evening, everyone. So we'll be discussing about a case who my patient is 11-month-old female who is hailing from Ahmedabad, the informant being the grandmother and the father. They brought the child with the chief complaints of not attending developmental milestones according to age and persistent abnormal body posture when awake. Since the history starts from development to delayed development, I would like to start from antenatal. And antenatal history-wise, it was a spontaneous twin conception, which was confirmed by ultrasonography. According to the mother, the first trimester, there was no history of fever with rash, no history of any teratogenic drug intake or any radiation exposure. In second trimester, the quickening was perceived at 5th month, and no history suggestive of blurring of vision, swelling of feet, blood transfusions, or abnormal sugar values recorded. In third trimester, the fetal movements were well perceived, no symptoms suggestive of PIH, gestational diabetes, and anemia. The growth scans showed that both the babies were growing at a lesser rate than normal, but there were no Linear abnormalities detected, and the mother was not aware of the blood group. Coming to the birth history, it was a term gestation delivered at 37 weeks by normal vaginal delivery. The present baby is a twin one whose birth weight was 2.3 kgs, cried immediately after birth. Baby was discharged on postnatal day 3, admitted to NICU on postnatal day 5 in view of yellowish discoloration of body, kept under blue light for 36 to 48 hours, and then discharged. And no other complaints were informed. The twin 2 was a girl again. The birth weight was 2.2 kgs, cried immediately after birth, and discharged along with the twin 1 on postnatal day 3. Coming to the history of presenting illness, the main complaint was not attaining developmental milestones according to age. So according to the developmental history, the gross motor wise head holding was not attained at all. And whenever the baby was put in prone position, according to them, the baby used to lift her head partially. Fine motor wise, the baby started to bring hands towards her mouth at 5 months, from 5 months of age, but there was no spontaneous reaching out for objects ever attained. Speech and language wise, cooing, the baby started to develop at 3 to 4 months, and social smile was seen at around 3 to 4 months of age. So going to the global developmental IQ quotient was to 20%, and thus she fits into global developmental delay in more than 2 milestones. History continued. There were history of abnormal body postures noticed since 4 months of age in the form of twisting of limbs with generalized tightening, arcing of back, and when noticed predominantly when she tries to roll over and is active. The tightening disappears during sleep, and no associated uprolling of eyeballs or tonic-clonic movements during such episodes noticed by the parents. The baby had an episode of involuntary movement of all limbs in the form of tightening with to and fro movements associated with uprolling of eyeballs, lasted for 20 to 30 minutes, but this was not associated fever at around 6 months of age, for which the child was admitted and received some IV injections for 14 days. They were able to differentiate the movements which are seen previously and this one separately. CSF analysis was done and was informed to be normal, and was said that the child has developmental delay due to some insult during birth and due to jaundice during the early neonatal period. Following this episode, the child was not smiling at parents, not feeding properly, spits out the food whenever kept in mouth. There were no cooing sounds which were present earlier. There was also no adequate weight gain. The twisting movements increased in frequency, but they were not associated with any crying episodes, and rather the baby did not respond or did not make much sounds later, tries to roll over and get stuck in that position with extended upper and lower limbs. There were no diurnal variation in these apart from they were not absent, they were not seen during sleep. There are no fixation of objects and no response to sound. Then there was no other gain in further milestones. There was occasional upward fixation of eyes seen with normal blinking, no to and fro movements or any other abnormal movements of eyeballs. There is also associated history of difficulty in passing stools once in 4 to 5 days, hard formed stools, doesn't cry for any needs. The parents just feed based on time, no other bladder retention or urinary retention issues. No history of regurgitation of feeds, drooling of saliva, recurrent infections, or further episodes of seizures later, and no hospitalization required for any of the illnesses. The baby is not on any anti-seizure medication. And no history of any abnormal color of urine or progressive increase in head size noticed by the attenders. Family history, the child is a third born child of a non-consanguineous couple. The second sibling is a girl, died within 3 hours of birth due to query birth asphyxia. The other twin, the twin 2, expired at 6 months of age due to vomiting and loose stools. But on provocation, they are saying that this baby also had the twisting movements like that of our index case. And our case is presently 11 months old. And there is a normal 4-year-old elder sibling. Coming to nutrition history, the baby is predominantly fed with semi-solid consistency food as she spits out food kept in her mouth. The required calories and proteins being 520 kilocalories per day and 10.9 grams per day, but the intake is approximately 230 kilocalories per day and 6 grams of protein per day, but she spits out predominantly. Vaccination history, she is partially vaccinated, birth vaccines alone were taken, and socioeconomic history wise, the family belongs to a lower middle class family. So coming to summary, we have a 11-month-old female infant whose third-born child to a non-consanguineous couple and was brought with complaints of delayed attainment of milestones which were seen in all domains associated with twisting movements of limbs and body, whose clinical status regressed after onset of a seizure episode at 6 months of age with loss of previously acquired minimal milestones and has poor weight gain and constipation. Along with that, there is obvious no history of vision. There is suggestive of vision abnormality and also hearing abnormality. There is significant family history of death of 2 siblings, an elderly at 3 years of life due to birth asphyxia, and the other twin with almost similar complaints. So keeping this in mind, it looks like a progressive encephalopathy, which has involved both the cognitive as well as the abnormal limb movement showing some white matter involvement. So it is a progressive disorder or a progressive encephalopathy with involvement of both gray and white matter. And my differentials at this point of time are neurometabolic disorders, including organic acidemias, and in view of multiple deaths in the family, I will also consider trying to think about mitochondrial disorders.
Dr. Sandeep,
yes,
can you elaborate that why you, with this history, what are the points which favors you to think about the progressive versus the static encephalopathy?
Though there is a history of query neonatal jaundice at birth, which is relative significant history with the histories which is in the form of twisting postures, which can be seen as a form or sequelae of kernicterus. The baby, according to them, has lost the previously acquired milestones, which is significantly towards a regressive disorder. As in a static disorder, there will be no attainment of new milestones, but the previous ones which were present will not disappear. And the second thing was the cognition aspect also, the baby looks to be on a falling trend rather than gaining new or being at the same level of developmental milestone that the baby had previously received. And is also associated tone abnormalities, or the abnormal posture can be suggestive of white matter involvement also.
Yes, thank you. So it's very important when you have already delay, and when there is a arrest in that delay of the delaying milestone, although child is gaining but delay. So whenever there is an arrest or even there is a regression of the attained milestone, that always indicative something the pathophysiology is still going on. So it points toward the progressive encephalopathy, and it's a good idea to tabulate the developmental milestone. So whatever the maximum attained milestone till date the child has, and right now the present current status of the milestone. So it give you very clear idea that this is the highest achievement of the milestone, and now at this point of time child is doing this much. So it has a very clear idea of loss of or the regression of the milestones.
Okay.
Thank you.
Okay, Dhruv, can we comment on DQ without formal developmental assessment or examination? Dr. Sridhar has asked this question. We have told no, DQ is 20%.
Yes, sir. The developmental quotient which was actually calculated was the maximum milestone that the baby has achieved, sir. But on history, when they later said that the attained milestones also regressed, that particular developmental quotient actually falls below than the acquired thing. And the assessment of development actually is part of.
Would you comment? I mean, formal developmental assessment is necessary, or yes, we can do it in exam like he has.
We can do it in during the history itself.
Yeah.
So developmental quotient word can be used without formal assessment. That is what Dr. Sridhar was, I think, meant to be asked. So for developmental quotient, we need proper examination. On history, we can have a rough idea. We can say that. But for developmental quotient, if you want to comment, it required proper developmental assessment and for the further testing and employment of that particular testing, and then we can derive upon that particular DQ.
Okay.
And another question is, did second child die due to asphyxia or had any abnormal facies or drops or anything else? Somebody
according to the attenders, the second child, they are telling the baby did not cry at birth, and they tried to kept the baby in NICU, but after 3 hours the baby, they said that the baby expired, but no obvious dysmorphic features according to the mentions. Okay. We don't know whether the same disease or it's a purely asphyxia related death.
Right, go on.
Okay, I'll proceed to examination.
Yeah, please.
Okay. So on examination, the child was examined during sleeping as well as an awake state. During sleep, the child is sleeping comfortably, no abnormal posture, but the baby looks grossly undernourished. But when the child is awake, the baby was seen to have some abnormal twisting movements and persistent, almost like atonic neck reflex kind of a posture was present whenever the child is active and having spontaneous movements. Coming vitals wise, they were stable with a stable heart rate, respiratory rate, and saturation, no tachypnea and any suggestive of LRI. And no obvious dysmorphic features were seen, no neurocutaneous markers apart from a small hemangioma over the Ziffy sternum. Anterior fontanelle was normal, which allowing tip of the finger, rest head to toe examination was normal. Anthropometry wise, for 11-month-old, she was just 3.8 kgs. She was gross, severely underweight. Lengthwise 60 centimeters, severe stunting. And head circumference wise, she falls in 37.5 centimeters with severe microcephaly. On systemic examination, going to central nervous system, higher mental functions wise, the child was moving around, looking around, but she was not interested in surroundings, but she was not fixating on any objects also. Cranial nerves wise, cranial nerve 1 couldn't be examined. No visual fixation to objects were seen, but blinks in response to bright light. Pupils were equal and reactive to light, then the fundus was normal. Cranial nerve 3, 4, 6 wise, there was no squint, no restriction of ocular, extraocular movements, and no nystagmoid movements seen. Sensations couldn't be checked, but chewing movements were normal for 5th cranial nerve examination. Facial 6th, 7th nerve, there were no any facial asymmetry. The 8th nerve, there was no significant response or in the form of startle or sudden localization to sound seen during the examination. 9th and 10th, gag reflex was present. 11th, spontaneous head tilting to both sides seen. And 12th cranial nerve, no tongue fasciculations or atrophy and any deviation of tongue to any specific side. Coming to motor system examination. So when awake, the baby had persistent arcing of the back within the form of opisthotonous posturing with even retrocollis kind of a stuff. Where she tries to roll over, but she just gets stuck in the same position and she keeps on trying to do the same thing. Bulk is symmetrical, but undernourished grossly in all the 4 limbs. The tone was normal during sleep, but during when awakening, the tone is diffuse tightening during entire range of motion was seen. That was not velocity dependent. Independent of velocity in both the extensors as well as the flexors, the tone remained to be in the same position and the same extent, and there was no change in tone with respect to velocity. And that is suggestive of dystonia, and it was generalized and it was not a focal. And the power, as we can see, is the baby is able to move limb against gravity and even to quite some resistance, and the power is more than 3/5 in all limbs. And the reflexes wise, they were during sleep, we can see the baby doesn't have any specific posture, which we can see later also. Sorry. The exaggerated both upper limb and as well as lower limb reflexes were seen, and bilateral plantars were extensor. Superficial reflex were intact. As we can see here, the baby has exaggerated deep tendon reflexes, even with response to single finger tap itself, and even plantars were extensor. And this spontaneous positioning without even touching the baby is indicative of striatal toe, where even on before touching the baby for a plantar itself, the child had striatal toe, which is a suggestive or indicative of a localization to basal ganglia. And as we can see here, during sleep, the tone is completely normal. Then there is no restriction of movements to tone. There are no other cerebellar signs, no neck rigidity, no autonomic disturbances, and the spine was also normal. Coming the rest systemic examination like cardiovascular system, respiratory system, and perabdomen, there were no organomegaly, there was no any cardiac murmur detected, and bilateral ear entry was equal with no any added sounds. So coming to a summary of the case right now, it's 11-month-old female infant, third-born child to a non-consanguineous couple with history of neonatal jaundice. One was brought with global developmental delay, whose clinical status regressed after onset of a seizure episode at 6 months of age, with loss of previously acquired milestones, and has poor weight gain, constipation, with improper vaccination, and results poor nutritional history, and has significant family history in the form of death of 2 siblings, and elderly at 3 loss of life due to query birth asphyxia, and the other twin with almost similar complaints, but who died because of vomiting and loose stools, who on examination is severely undernourished with microcephaly, with tone abnormality in the form of dystonia, and also upper motor neuron pyramidal signs present with no obvious dysmorphic features. And thus keeping these as my main right now, we have strong global developmental delay, regression of milestones, positive family history, grossly undernourishment, along with main in the form of tone abnormality in the form of dystonia, along with upper motor neuron signs, with vision as well as hearing involvement query. So thus my differential diagnosis are a regressive disorder. So because of the significant family history and another sibling involvement, that is another twin, we would like to consider mitochondrial disorders, glutaric aciduria type 1, or any organic acidemias like propanol acidemia or methylmalonic acidemia, neurotransmitter related disorders like any tetrahydrobiopterin deficiency related disorders, and leukodystrophies, which predominantly have basal ganglia involvement, as I would like to localize the lesion predominantly to basal ganglia, thalamus, and the pyramidal tracts.
Can it be any storage disorder also, Dhruv?
Like
TSI
organomegaly was not seen, sir. And fundus, there was no any obvious cherry red spots. These two were relatively to another. Neurologically, main Niemann-Pick and those neurotype C, but those were other possibilities which can.
Okay. So Dr. Jeevan is also told differential NBI would be there as a differential. Brain iron accumulation disorders.
Brain, yes, sir. Brain iron accumulation disorders. Dopamine.
Okay. And what about Cockayne syndrome?
No obvious dysmorphisms were seen in this.
Okay. Right. So, Harsh, any comments?
Yeah. Would you like to, whatever the differentials you have put, even Dr. Sangeeta has commented that AADC deficiency, which is a part of neurotransmitter related disorders. So in this category, why you think that mitochondrial should be on the first differentials above the glutaric aciduria type 1 or even neurotransmitter related disorders? Any consideration for the same?
Okay. First thing was the baby had a relatively normal early infancy or a neonatal period. The baby had developmental delay, but was acquiring some milestone. The baby had a catastrophic event, following which there was a regression in milestones. And the associated movement abnormalities were in the form of dystonia. Because of this, I would like to consider mitochondrial. And with the family history significantly on the seen in the other twin also, though the mother is normal, and the second sibling, we don't know what actually happened, query birth asphyxia or any other abnormality. The usually glutaric aciduria and organic acidemia present early in neonatal period, at least early in neonatal and infancy period, with almost similar history in the form of poor weight gain, but they will have tachypnea and frequent admissions because of that secondary to acidosis and stuff. Neurotransmitter related disorders in the form of but tetrahydrobiopterin usually have some phenylalanine excess or low related states, which can have some orders or melanin metabolism effect also can be seen in certain. And leukodystrophies, no obvious dystrophies, and glutaric aciduria and leukodystrophies like Alexander usually has macrocephaly rather than here we in the form of we have a microcephalic kind of a baby here.
True. So usually, yeah. So glutaric aciduria type 1 is, they usually present with the dystonia predominantly, but they have relatively preserved head size or towards the larger or the microcephaly. Microcephaly a bit unusual, but yeah, it can be present, not like that, but yes, it is less known. And neurotransmitter related disorders, even as you have mentioned, that biotetrahydroferritin, along with there is a dopamine deficiency related state, which is AADC, is the most common disease that can also have a similar presentation. But so I think we are okay with that. Dr. Gurpreet, any more DDs you would like to add, or?
Yeah, people are adding DDs. There are so many. Like the child has hypopigmented hair, so can it be PKU?
Yes.
It can also be like early infantile Krabbe's disease. So, anything? What is against Krabbe's disease, Dr. Dhruv? Can you just?
Yes, sir. Dysmorphism, macrocephaly usually will be seen there, and predominant white matter signs also will be seen more compared to dystonic kind of features.
Okay. Hikari-Guttry is also another possibility which was kept. And how are the hair of the child? Can it be Menkes? Hair.
You want me to show the picture again, sir?
Yeah. The hair looks pretty normal. Yeah. Okay, I think there's a long list of differentials starting from leukodystrophy and others he has discussed well. So I think we can go ahead.
Okay, sir. Shall I go ahead, sir?
Yes, please.
Okay, so here we have come across the child predominantly with developmental regression, and in the examination we have found dystonia, and we are probably thinking of a diagnosis towards a mitochondrial disorder. So I would like to go ahead with the case in the form of how can we approach a case of dystonia. So dystonia basically stands with definition wise, it's an abnormal, repetitive or sustained movement or postures secondary to abnormal contractions of the muscles, which can be intermittent or sustained. So when we have classification of dystonia, we have based on two axes. That is, one is based on clinical characteristics and the second one being the etiology. Based on clinical characteristics, we define we have four features on which is the age of onset, based on the distribution where dystonia is predominantly seen, what can be the likely cause or the course of the pattern of the scene, and associated features if at all present. So age of onset, our child belongs into infancy. Infancy starts from neonatal period to 2 years, childhood from 3 to 12 years, adolescence from 13 to 20 years, early adulthood from 21 to 40, and late adulthood being beyond 40 years of age. So based on focal also, we can have based on body distribution, we can have focal dystonia, which is only one body is affected. Usually we have features like oromandibular dystonia or even just upper limb dystonia. Segmental involves two contiguous body regions which are involved. Multifocal are two non-contiguous body regions which are involved, which can be either upper limb or one side and the lower limb of other side. Generalized is what we have in our case, where the trunk and at least two other body sites are which are if involved. Trunk with two other body sites, if at all seen, they are generalized. And hemi is only one half of the body is restricted. Coming to the temporal pattern, whether it is a static or progressive. Static usually is in the form of cerebral palsy and that kind of encephalopathy. And progressive is the majority of primary pediatric dystonias have a progressive course like what we are seeing in our case. Based on variability, whether it is persistent, that is, it is persistent irrespective of anything, that is, it's same throughout the day. Action specific, when we try to do any specific action, it is associated. Here, the example they have given is a writer's cramp. And diurnal fluctuation, whether they vary with day and night phenomenon. And paroxysmal is when it occurs when it is triggered by a specific issue, like example, movement or exercise-induced drowsiness. And last, associated features include whether it's associated with any CNS complaints or CNS features. Isolated is with dystonia only without tremor. Combined dystonia is with other movement disorder like ataxia, chorea, or Parkinsonism. And complex dystonia is like here we have seen with spasticity or any systemic manifestations. So coming to etiology based, whether it's a nervous system pathology or inwired, that is genetic issues. Nervous system include evidence of degeneration, evidence of structural lesion, or no evidence of degeneration or structural lesion at all. And inherited or acquired include inherited causes and other ways of inheritance in which dystonia can be acquired. So R, if we find to classify, it's R as infantile dystonia, which is generalized dystonia and has a progressive course, which is persistent, and it's a complex. So this is what our child fits into. So if we have an infant with dystonia, how do we have to go ahead? So that is the approach of dystonia. Sorry. So we have to look for what is the causes for it. We have to see the triggers which are seen, whether it impacts in activities of daily living and quality of life, and any red flag signs for this genetic cause, like in our case, birth and medical histories and associated comorbidities. Examination wise, whether it is fitting into dystonia definition, which is non-velocity dependent, abnormal posturing which are seen, striatal toe, coexisting spasticity, and look for additional signs. So all cases of dystonia, the first feature that we have to do is MRI brain. If at all it is suggestive of kernicterus or hypoxic ischemic feature kind of an MRI issue, then we don't have to further evaluate. If it is not, then we have to go ahead with evaluation. It can be having a normal MRI brain or it can have an abnormal MRI brain. Whenever we have a normal MRI brain, we have to consider primarily dopamine responsive dystonia. So a trial of dopamine is suggested in all cases of normal MRI brain. When we go to abnormal MRI brain, based on the evidence that we get, we have a lot of investigations, as we just saw, a lot of differential diagnosis, and we try to go ahead with one after the other to rule out other neurometabolic disorders. And finally, we have genetic tests that have to be done. And as progressing to our case, so after, as we saw in the approach, after we got an dystonia, we had and progressed with our MRI brain. So this is a T1 weighted image, and with the white matter is white and gray matter is gray and CSF is black. And this is the axial section of T1 weighted image at the level of midbrain, where we can see there is a significant hypo-intense lesion which is surrounding the cerebral aqueduct and predominantly concentrated over the posterior aspect of the midbrain, and that is around the tectum of midbrain, and also involving some amount of tegmentum. As we see the same image in T2 weighted intensity axial section, we can see the significant hyperintense bright lesion on which is symmetric and involving the same area as in T1 on both sides. And this is the T2 flare image, which is seen, which is shown as T2 hyperintense flare in this axial cut section of the same area. And when we see T2 intensity, when we go higher up, we can see the base thalamic regions here, which has symmetrical in T2 hyperintense lesions in bilateral medial aspect of thalamus, which is very important to note down here. And we can see the basal ganglia is relatively normal. And as we come to the diffusion weighted images of at the level of midbrain and at the level of thalamus, we can see significant diffusion restriction seen as a hyperintense signal at the posterior aspect of the midbrain, as well as the medial aspects of the thalamus, which are coinciding with the features that we just saw in T2 weighted image as well as T1 weighted image. So this is suggestive of a significant necrotizing lesion involving the posterior aspect of midbrain as well as the thalamus. And further explanation and better explanation can be given by Dr. Atin sir as we progress later in the class, and I will progress with this. So with these clinical features and the radio imaging features in the form of bilateral symmetric T2 hyperintensities involving the thalamus as well as the midbrain, we were in a clinico-radiological diagnosis, we were keeping it as a mitochondrial disorder, predominantly as a Lake syndrome in this case. So before going ahead, So some treatable cause of dystonia is also one more thing to be seen as they respond to it significantly. The few major important ones being biotin and thiamine responsive basal ganglia disease, which is a genetically acquired disease, which has abrupt onset in early childhood, which has dystonia, subacute encephalopathy, dysarthria, external ophthalmoplegia, and seizures, which is also very important. And it responds significantly to oral biotin and thiamine. And that is why this is important to know, as well as biotinase deficiency, which is given by oral biotin supplementation, and which also has encephalopathy with motor delay, ataxia, dystonia, as well as seizures. And something else, this is more important, which is dopa responsive dystonia. We have to consider trial of levodopa in any case whose MRI is normal with relatively normal development also. And other cases, as we were discussing during the differentials, like glutaric aciduria type 1, other organic acidemias in form of methylmalonic and propionic aciduria, which involves avoiding the specific diet and try to improve them. And finally, we have one of the mitochondrial disorders in the form of pyruvate dehydrogenase deficiency, which is better by thiamine, which is a cofactor for the enzyme, as well as Wilson's disease, we all know, which also can present with dystonia. So this is a table which is derived from an article, journal claim dystonia itself, for some treatable cause of dystonia. And in this, we would like to add one more component as we're discussing about dystonia, which is status dystonicus. So what is status dystonicus? It's a life-threatening emergency characterized by the development of increasingly frequent or continuous severe episodes of generalized dystonic spasms in the form of contractions, and it requires urgent hospital management. This can be of two types clinically, which is tonic or phasic. Tonic is, it is sustained contraction, which is not having any phase of relaxation in between, almost like status epilepticus, and phasic phenotype, which has intermittent but multiple frequency with an interval of very small interval in between the contractions. It's almost like status epilepticus, that is multiple frequency of seizures without regaining of consciousness. And it is characterized by bulbar weakness, compromising airway patency, progressive impairment of respiratory function, which leads to respiratory failure, metabolic derangements, as well as exhaustion and pain. The metabolic derangement is mainly due to the muscle breakdown, which leads to rhabdomyolysis, leading to acute kidney injury secondary to the enzymes released from the muscles, and exhaustion and pain due to excessive workload done by the muscles. They get tired, and the pain is also due to the muscle breakdown. So the trigger factors include infections. They are mainly seen in secondary dystonia. Like why we are discussing this is any case of cerebral palsy can land to us with status dystonicus, and that is why which is important for us to know. The infections include mainly acute gastroenteritis with dehydration, others in the form of trauma, surgical procedures, anesthesia, any decompensation of a known previous underlying metabolic disorder, stress, pain, significant gastroesophageal reflux disease, and constipation also can trigger them. Certain drugs which can precipitate them include haloperidol, which is a dopamine antagonist, pimozide, also the same, metoclopramide, which is frequently used for vomiting, benzodiazepine, withdrawal. After when the baby is on diazepam or clonazepam daily dose, when we withdraw, they can precipitate a status dystonicus. And 1/3 cases have unknown trigger. So mainly, as we already discussed, the complications include respiratory failure, which can be due to bulbar spasm, diaphragmatic dystonia also, rhabdomyolysis and myoglobinemia, electrolyte acid-based disturbances secondary to significant metabolic acidosis, and hyperkalemia. Secondary complications such as dysphagia, anarthria, thrombosis, and gastric bleeding, injuries, even fractures. The contraction can be so hard to cause fractures, and it also cause sepsis. So this is a table which we took it from AAP, that is American Academy of Cerebral Palsy and Developmental Medicine, which gives a grading of dystonia. This is called Dystonia Severity Action Plan, which is divided based on the comfortness of the baby. If it sits comfortably stable, it's grade 1. It's relatively irritable, but can be made and relatively stable on medications, grade 2. We are going to concentrate on grade 3 and grade 4 and grade 5 here. But this is pre-dys status and this is obvious status dystonicus. And when primarily we have, as we saw the complications, our main treatments goes with supportive care in the form of urgent admission, ICU care, hydration, antipyretics, analgesia, and monitoring parameters. This is pre-status dystonicus care. And temporizing measures including sedative hypnotic in the form of oral chloral hydrate, 30 to 100 mg per kg, and non-respiratory depressant as they can go for respiratory depression with the drug as well as the due to the disease per se, includes in the form of clonidine, sedative hypnotic like avimidazolam slowly, And general anesthesia, if at all we cannot go ahead, we have to intubate and go with general anesthesia with propofol. And finally, paralytic agents in the form of pancuronium. And dystonia specific, non-invasive and invasive. Non-invasive includes oral therapy in the form of trihexyphilidin, tetrabenazine, and trial of baclofen, benzodiazepine, gabapentin, and levodopa finally. And invasive includes intrathecal baclofen, deep brain stimulation of the globus pallidus interna, as well as pallidotomy. So this is an overview of status dystonicus, which can present as a life-threatening emergency. And this is general management of dystonia, which we have already seen. One thing is, if at all there is a focal dystonia, we can consider giving botulinum toxin locally injection, which can improve the state. And in generalized dystonia, we have trihexyphenidyl, which is an anticholinergic drug, which is also usually called as pacitane. Baclofen, which is a GABA B agonist, which doesn't act on the GABA A receptor as benzodiazepine as phenobarbital. Tetrabenazine is a monoamine oxidase inhibitor, and carbamazepine is a sodium channel blocker, which also can be used. And others include intrathecal baclofen, as we saw, botulinum toxin injections, and deep brain stimulation as the last resort if they are not controlled with oral medications. And the other part that we were concerned about is in our case is in the form of whether it's a suspected mitochondrial disorders. So in brief, we will see why is it important. So as we all know, mitochondria is the powerhouse of the cell. What is the main function? It is responsible for ATP production through oxidative phosphorylation, where we have the cytoplasm, outer membrane, the intermembrane space, the inner membrane, and the mitochondrial matrix. And in the inner membrane, we have a system of enzymes in the form of complexes, which is responsible for ATP production through the transport of electrons along the chain. And as the electrons travel across, there is transport of hydrogen, that is proton, from the inner membrane to the intermembrane space. So this increases a proton gradient, which at the end of the 4 complexes, when it comes to the 5th, there is transfer of proton again from intermembrane space to the inner membrane, which is responsible for conversion of ADP to ATP. So this sequence or this complex of enzymes are very important. The first one being NADH oxidoreductase, the third of which we have to know about the complex 1, complex 3, and complex 4. Complex 2 is predominant, not entire, it doesn't traverse along the entire space of the inner membrane. And it's not actively involved, but it is mainly responsible with flavin adenine mononucleotide and dinucleotide transversion which is mainly from succinate from the Krebs cycle. So we should know about your unit 1, complex 1, complex 3, and complex 4 with respect to what? That is what we have to see. As they are energy source, they are required in organs which has required maximum number of energy in the form of brain and muscles. So this is one thing of mitochondrial DNA, which is in the cytoplasm. It is different from nuclear because it is transcription inside the mitochondrion. They have no introns. Introns are non-coded areas which are seen in the DNA and mRNA, but mitochondrial DNA doesn't contain introns. It is inherited exclusively through the maternal line. If the mother is infected, she can pass it on to all her progenies, but how much they can have the disease depends on the amount of mitochondria which is actually mutated. As each cell has thousands of mitochondria and multiple cells are there in a body, the disease manifestation depends on the number of mitochondria which are actually mutated, and that is called as heteroplasmy. So severe disease means more amount of mitochondria is actually mutated. But one thing we have to remember, yes, sir.
Sorry to interrupt. Can you be a bit quick and discuss the maybe final diagnosis or your provisional diagnosis in this case, and go to the MRI discussion by Dr. Atin?
Yes,
time is a little less. Yeah.
Yes, I'm done, sir. The only one thing which we need to know is mitochondria, though we are speaking of mitochondrial DNA, almost 90 genes are encoded from nuclear DNA also. So it is not always the mitochondrial DNA which is at fault whenever we are considering a mitochondrial disorder. We should also think about the nuclear DNA defects, which can lead to mitochondrial DNA, mitochondrial disorders. I'll skip this. And this is what we are thinking of our provisional diagnosis today, which is a subacute necrotizing encephalopathy. Why we are considering this? So this is characterized by neurodegenerative disease with variable symptoms due to mitochondrial dysfunction, which is caused, we have neurodegenerative area in this case. Mitochondrial dysfunction caused by hereditary genetic defect. We don't have a clinical, genetic diagnosis in our case to say this. And there are bilateral CNS lesions that can be associated with further abnormalities in diagnostic imaging. So when we are not having all the features fulfilled, we call such a disease as lake-like syndrome. So our provisional diagnosis for our case is lake-like syndrome, and it is associated with deficiencies of any of the features that we just saw, oxidative phosphorylation problems. And the underlying mutations may be found in nuclear DNA or mitochondrial DNA. So this is important so that whenever we are sending genetic analysis, we should make sure that we send both the nuclear DNA sequence, whole exome sequence or clinical exome sequencing, as well as we have to send for mitochondrial DNA. So onset, as in our case, infancy and early childhood, followed by rapid deterioration, usually triggered by infection and other metabolic changes. Initially, there is developmental regression with loss of previously acquired skills, and the symptoms can be in the form of hypotonia, spasticity, or dystonia, seizures, which is mainly in our case with abnormal eye movements or slow saccades, and predominantly basal ganglia and brain symptoms, which are the features of Lake syndrome. And laboratory findings wise, if at all we had chance to evaluate this baby further, we would have had severe lactic acidosis or acidemia, because pyruvate is changed to enters into the oscillation respiratory, and the respiratory electron transport chain and Krebs cycle. Most of pyruvate is converted to alanine. That is why there is hyperalinemia, and urinary organic acids to be looked out for in the form of pyruvate and other mediators. Carnitine panel is important as they can be due to carnitine deficiency also. And general laboratory panel is one more thing. And MRI findings in legs, as in our case, is bilateral symmetrical hyperintensities in T2 weighted images, involving basal ganglia, predominantly putamen and thalamus. And there's a lactate peak in the brain parenchyma, when we are focused, and that is which sir can be better to explain about. And this is the differential diagnosis for Lake syndrome, which we also have to consider in our case. And this is the treatment overview, which is mainly nutraceuticals. And finally, I would like to end with just one slide. Though we are considering about these, I would like to even just include that kernicterus is predominantly globus pallidus, which is seen as T2 hyperintensities, which are symmetrically seen as in this case. And this is a case of cerebral palsy, which is dyskinetic, where we can see it is the which is the posterior putamen, and the ventrolateral thalamus, which has the hyperintensity seen. In contrast to our case, as they also had a history of neonatal jaundice, our case had significant ventromedial involvement of the thalamus as well as in the midbrain. Yes, sir. I'm done, sir.
Okay, I think I'll invite Atin sir now to discuss the MRI differentials and how to approach a basal ganglia disease. Although he has, Dhruv has discussed very nicely. Dhruv, very nice presentation.
Thank you, sir.
The thing is, we needed to be a bit quick.
Yes.
And Atin sir, if you can discuss one chat message by Dr. Nihal also, that it can be some smiling clown sign of tegmentum, mitochondrial DNA and RMND. So what is that? We are not aware of it.
In fact, I am also not aware. I saw Nihal's message. So
Yeah.
I think it's
So we
something.
can invite Dr. Nihal also to.
Yeah.
put
Nihal
some
will
light.
also actually be good to throw some light on that. I think he's quoting Dr. Cesar Alves, who's actually one of the strong person in mitochondrial disorders. He's doing a lot of work. So, in fact, Dr. Gurpreet, sorry, but I somehow did not make my presentation based on basal ganglia differentials. I made it on lesions which suggest us to be mitochondrial disorders, or lesions which are certainly characteristic for mitochondrial. And maybe I'll discuss some of the basal ganglia differentials as I go along, right?
Yeah, sure.
Okay, just a second. Right. So since we were discussing mitochondrial disorders today, and I got to know last webinar also. So basically, when do we suspect mitochondrial disorders radiologically? Mitochondrial disorders have a very varied spectrum radiologically. It is often a clinical and a radiological combination which helps us to reach to a diagnosis, of course, aided by genetic testing, which is required, gene testing. However, once you are suspecting any mitochondrial disorder and when you get an MRI done, then there is a whole spectrum which can be suggestive. But if you see changes predominantly in the basal ganglia, including the thalamus, changes in the brainstem, or changes in the white matter specifically a leukodystrophy, which is like a cavitating type of a leukodystrophy, with especially involvement of the corpus callosum. Changes in the cerebellum, which may be signal changes in the cerebellum or cerebellar atrophy, or changes in the spinal cord. Right. So I have practically covered, you may say, almost everything. Right. But the point here is a combination of more than at least two of these things getting involved together, two or three things getting involved together, you need to suspect mitochondrial disorder in the right clinical setting significantly. In isolation, even one of these lesions structures can be involved in mitochondrial. Even then we have to think, but a combination of two or three out of basal ganglia, brainstem, cerebellum, a combination of at least two out of these three together is a strong marker that you need to keep mitochondrial disorder as a good differential. And if we're talking in terms of a leukodystrophy, like a pattern, we know there are different leukodystrophies, which are the first differentials. However, if you see a cavitation or cystic changes in a leukodystrophy, then mitochondrial classically comes into the picture, because the more common leukodystrophies which do show some cystic changes are vanishing white matter. I'm sure we can easily differentiate that by clinical picture also, or by a radiological picture also, which there is a usual uniform rarefaction of white matter in vanishing white matter, which is predominantly a periventricular, usually does not involve the corpus callosum. And even if it involves the corpus callosum, it will involve only the inner or the lower rim of the corpus callosum, whereas the middle part of the corpus callosum and the superior rim is completely spared in a vanishing white matter. Whereas a cavitating type of a leukodystrophy, which is because of mitochondrial disorder, would typically have large, more well-defined cystic changes, especially if it is a complex 1 type of a deficiency or a 2, or a small well-defined cystic changes if you go towards complex 3 or 4. And in corpus callosum, it is one of the earlier structures to get involved, which is usually significantly enlarged and shows a very large predominant cystic changes, which involves the middle blade of the corpus callosum. That's the pattern of mitochondrial leukodystrophy, right? Second is, if you see calcification, especially in the basal ganglia, again, mitochondrial comes into the picture. I'll go on to further slides to tell which all mitochondrial disorders you need to consider. But if you see this, and especially if you ruled out calcium metabolism disorders, then mitochondrial is one good possibility which you need to consider. Again, if you have associated either brainstem or basal ganglia abnormalities, then this becomes a very good differential. White matter cavitation, I have stressed enough to tell that it needs to be considered for a differential for a mitochondrial disorder. Then there are other abnormalities which also may be seen with mitochondrial disorders. All of these per se are not specific at all for mitochondrial, but again, in the right clinical settings and in combination with the above three, which are the most common ones, these can also be suggestive, like pure atrophy, cerebral atrophy, some form of delayed or hypomyelination, some abnormalities of the corpus callosum, either agenesis or dysgenesis, subependymal cysts, optic nerve atrophy, and aided by a abnormal lactate visualized on MR spectroscopy. Again, we all need to understand that elevated lactate is not a clear marker for mitochondrial, because it may be seen in ischemia, it may be seen with necrotic lesions also. But in the setting when we are thinking in terms of a mitochondrial disorder, and you do a MR spectroscopy and it shows a significantly elevated lactate, it definitely increases your confidence for diagnosing a mitochondrial disorder. So I'm taken some of my slides from predominantly 2 or 3 articles which I found good. One of them is this published in Radiographics, which is a good article on pediatric neuroimaging for pediatric mitochondrial disorders. So if you have a significant basal ganglia abnormality, especially the caudate and the putamen, or even the globus pallidus, the most common mitochondrial disorders which need to be considered are the Leigh spectrum, which the kind of clinical presentation with the radiological presentation we are seeing today, as well as Melas, melas besides the cortical abnormality also have usual involvement of the deep gray matter, that is the basal ganglia, and the Golgi spectrum of disorders. The globus pallidus, if you see in addition or in isolation, typically is seen more commonly with Kearns-Sayers, or if we're talking in terms of Leys, it is seen with PDH deficiency, specifically in one part, PDH-A1, the globus pallidus is involved. Otherwise, it is the caudate and the putamen. If you see them and you're thinking in terms of a mitochondrial, then you can think in terms of predominantly Leys and Melas. And calcification, again, these are the disorders which still have calcification, Melas and Leys, also seen predominantly in Kearns-Sayers syndrome. Cocaine is now also classified as a mitochondrial disorder. So this is a spectrum of Leys disease in which all these areas can be involved in different genes, which are ultimately leading on to a Leys type of a syndrome, like some which we saw in our case. So you could have predominantly basal ganglia abnormality, the caudate and the putamen, the thalamic abnormality, only the globus pallidi abnormality, which I told you could be seen with a PDH deficiency type of a disorder. Then there could be thalamic involvement and a brainstem involvement, especially the periaqueductal gray matter or the midbrain tegmentum. This is something which we were seeing in our case today, almost a similar pattern of a midbrain tegmentum leading on and reaching up to some thalamic involvement, which was seen in our case today. These are all classical abnormalities of Leys. But when it involves the brainstem, besides the midbrain, it can have a periaqueductal gray matter involvement. There can be a substantia nigra involvement, the pontine tegmentum involvement, and even medullary changes are seen. And this is another manifestations of Leys disease only. And in cerebellum, you can have a significant amount of cerebellar atrophy. Also, there could be in the medulla inferior olivary nuclei involvement. There could be dentate nuclei involvement. And rarely in Leys pattern, you also have cortical gray matter involvement or cystic white matter changes, which are, as you've seen in the last webinar, more commonly associated with complex 1 or 2 deficiency disorders, and rarely there could be spinal cord involvement also. So this was one example of a Kearns-Sayers disease. There was good early cerebellar atrophy. There was early involvement of the globus pallidi with involvement of the thalami. In this case, we're not seeing the characteristic subcortical white matter signal changes, but they are usually present. But this combination, the globus pallidi, thalami, cerebellar atrophy, if you also see in addition basal ganglia calcification, you may need to think in terms of a Kearns-Sayers disease. Let's talk about some cortical abnormality. Cortical signal changes may be seen with Melas or Golgi related disorders mainly. So Melas, we all know, typically have stroke-like episodes involving the parieto-occipital gray matters, which may be fleeting, coming in one lobe and then gradually improving. Then over a period of some time, it may become on the other side, especially in the parieto-occipital region. Then there can be cortical abnormality in forms of malformations, which are typically seen with either PDH complex deficiency or pyruvate carboxylase deficiency. You can have ranging from polymicrogyria to Lisson-Keffley type of a pattern in a PDH deficiency. Then there can be subependymal cysts, which are also seen in the similar disorders, the PDH deficiency as well as pyruvate carboxylase deficiency. So this was one example of a proven Melas disease in which there was almost a gray matter and some subcortical white matter involvement of the posterior temporal occipital lobe on the left side. Also, if you see, there is some involvement of the right side. These are fleeting opacities of different age. In a subacute stage, it may show some enhancement also. And this was a proven Melas, which also had arterial lactate, which was 11 at that particular point of time. And this is an example of a pyruvate dehydrogenase deficiency in which you have corpus callosum agenesis or dysgenesis specially associated. You do have significant ventriculomegaly. You can have subependymal cysts which get formed, and there is associated significant microcephaly also. A combination of these can help you to think in terms of a PDH deficiency disorder. I've already talked about this white matter disorder enough. You can have leukoencephalopathies and especially cavitating white matter in which multiple genes are involved, from NFU to NDUFS to even MRFs can have cavitation in the white matter. And the white matter involvement besides this complex 1, 2, 3, 4 deficiencies can also be seen with Golgi related disorders and Kearns-Sayers syndrome. I've already talked about Kearns-Sayers syndrome in which you classically have subcortical white matter involvement along with a deep gray matter involvement, which could be usually of the globus pallidus, some part of thalamus, and the white matter. The caudate and the putamen are reasonably late involved or spared in a Kern-Sayre syndrome. And if you see this in association with the basal ganglia calcification, which is definitely picked up on CT, you can make a diagnosis. The other differentials for a significant subcortical white matter involvement, if you see some predominant subcortical white matter involvement, especially with the basal ganglia involvement also, you have to think in terms of a L2 hydroxyglutaric aciduria. In that case, it's usually the caudate and the putamen which are more commonly involved and compared to Kern-Sayre syndrome, and you will not often find calcification in those cases. In fact, Kern-Sayre syndrome also has often involvement of the brainstem, very predominant involvement of the brainstem also. This was example of a complex one deficiency in which there was, as I've described, cystic changes in the corpus callosum, cystic changes in the white matter with a marked extensive leukodystrophy pattern. And if you see the corpus callosum, there is middle blade of the corpus callosum which is involved, which is swollen. And besides that, there is some involvement of the upper spinal cord and the brainstem also with elevated, significantly elevated lactate, right? Another case in which you have white matter involvement, which is characteristic, is a LBSL or the DAS2 mutation, actually, in which you have the periventricular white matter involvement, which is just limited to the periventricular white matter, usually not involving the subcortical white matter. There is characteristic involvement of the lower part of the brainstem. You can have involvement of the lower pons. You can have involvement of the spinal cord in which the lateral corticospinal tracts and the dorsal tracts are involved. So if you see this pattern in the spinal cord, it's very reasonably characteristic, especially if a long segment involvement along with white matter, periventricular white matter and a brainstem involvement. A combination of these together would make you think in terms of a LBSL disorder, right? So this is, again, we have discussed, in fact, you discussed it last webinar also about the patterns for mitochondrial leukodystrophies. Then coming to this also I've covered, so coming to thalamus. Thalamus is also involved in those disorders only which were typically involving the basal ganglia, the Leigh syndrome, the Melas, the Paul-G disorders, and even the Kern-Sayre syndrome I've already talked about. LON is one, which is basically a mitochondrial DNA disorder in which you do not have usually significant radiological findings. It's more of ophthalmological and a clinical diagnosis. You just can only see optic nerve thinning. So it is not specific in this particular case. This was one example in which there was a significant only brainstem involvement and a dentate nuclei involvement which was seen. And in this case, if you see this type of a pattern, you can think in terms of a basically, sorry, you can see in terms of a SERF1 mutation. And since we had a good brainstem involvement in our case, therefore SERF1 was also a differential which we need to think in terms of a only a brainstem, predominantly a brainstem involvement. Again, cerebellar atrophies, you need to consider Melas, Paul-G related disorders, even Kern-Sayre syndrome that I also talked about, right? And I think that's it about, okay. Brainstem basically, I've already talked about. You need to consider predominantly the most common thing is Leigh syndrome and then Kern-Sayre syndrome. It also has a significant brainstem involvement. Both of these typically will have a good basal ganglia involvement also. So brainstem and a basal ganglia involvement together, you need to think in terms of a Leigh syndrome or Kern-Sayre disorders. Spinal cord can also be seen with Paul-G disorders, but the specific ones which I've told you is about LBSL by looking at the specific pattern of the spinal cord abnormality, which is covered in this. And this was the disorder which I've already talked about. This is one good flowchart which has been recently published by a team from Shri Chitra, led by Dr. Bijoy. So this is a good algorithm which you can again refer to. So if it is a predominantly cortical, if you are suspecting a mitochondrial disorder and if it is a predominantly cortical involvement, then again you're thinking in terms of either a Melas or a Paul-G related disorders, right? If it is a predominant brainstem abnormality, I've already told you, you need to think in terms of Paul-G related disorders, Leigh's disease, even Kern-Sayre disease, or a SERF1 mutation like we saw a case. If it is a predominantly white matter involvement, then you see whether it is non-cavitating or cavitating. Non-cavitating, one classical one is LBSL, but you can also have OPA disorders. And if it is cavitating, then of course you need to think in terms of the complex 1, 2, 3, 4 deficiencies, especially the respiratory train deficiencies. And I've already talked to you about predominantly basal ganglia, which is the most common one is the classical Leigh syndrome. So this was a brief overview. In terms of the basal ganglia abnormalities, if you have symmetrical basal ganglia abnormalities, the other disorders you think in terms of are the organic acidemias, which you need to rule out, the propionic acidemia, methylmalonic acidemia, or then you also need to think in terms of biotin thiamine responsive basal ganglia disease. You need to think as already illustrated in today's presentation, you first by clinical findings itself need to rule out the more common ones, the hypoxic injury, which can actually have an involvement of the putamen as well as the thalamus, or even kernicterus if it is especially only the globus pallidus involvement, or even NBIA, which can lead to dystonias. But for NBIA, you will of course have mineral deposition, which will be best evident on your gradient sequences or the SWI sequences, which can clearly point out that it's a mineral deposition. Then the other disorders involving basal ganglia are Wilson's disease, in which you have predominantly caudate and putamen involvement. And again, there would be usually slight T1 hyperintensity on those in those disorders because of the copper deposition, and you will have classical clinical features. I think that's predominantly the list for the basal ganglia disorders which you need to consider.
Yeah, thank you, Dr. Athan. It was a very nice overview of mitochondrial, although cannot grasp everything here, but it's a very good discussion. So, Dr. Harsh, your final comments on the case and the discussion.
Yes, sir. So thank you very much, Atin sir. It's always pleasure to listen to you, and it was a very nice and crisp guidance. Dr. Sandeep, it was a nice case and nice presentation. So few of the comments I have read recently. Actually, the mutation we still are not able to get it because of the financial constraint. But the good thing is we are able to avail some fund for that. So we will send soon this genetic testing for this child. And whenever it is available to us, I will definitely share with you. And overall, so this is basically the presentation highlighted that even with the developmental delay, you can make out if there is a regression, you can just consider the progressive encephalopathy, which is separated from the static encephalopathy. And you have to approach the infantile onset dystonia as it is outlined in the presentation, that what kind of a thought process should be kept in our mind, how the imaging is very useful to decide then to recognize the pattern. And there are certain treatable causes also we have to keep in our mind. And whenever we are in appropriate clinical scenario, definitely we try to find out the treatable causes first, and also to give a particular therapeutic trial as and when required.
Yeah. So Dr. Anis Jamil is also saying that caudate nuclei are primarily involved in proterotic aciduria type 2. So Dr. Nihal has also mentioned about the sign he was talking about, smiling tegmentum. That is still not published, but he has given the link in the chat, so that the central regions of brain had more predominant involvement in mitochondrial DNA. And peripheral region and white matter were more common in nuclear DNA, but we'll read in the paper the details about it. So any final comments from any other panelists or any questions, or we can wind up? So I think thank you, Dr. Athan, Dr. Dhruv, Dr. Harsh for the wonderful presentation, and especially Dhruv for working hard on such a short notice. It was only told last week to present this case. So thank you everyone for chipping in, and have a nice day. Thank you.
Thank you, sir. Thank you, sir.
Thank you so much. Thank you for this opportunity.